Hi, Susan. Welcome. Thank you so much for taking time to chat with me and my listeners.
Oh my gosh, I am so excited. I am a huge fan of yours. Ever since you popped up on my radar on Instagram, I've just been obsessed with your work. So
Oh,
I
thank you
am
so much.
a huge fan. And then I bought your book. So if
Oh,
you
thank
don't
you.
have the book, I highly recommend it, especially if you work in Urogyne or female healthcare, obstetrics, gynecology. It's great. And I didn't realize Toscarino wrote your foreword. I was a
She's a
huge
good
fan
friend of
of
mine.
Toscarino. I had every book, Eat Clean, that she published. So,
It's
uh,
funny, around the time that she was writing her books, I that's how I was sort of first introduced to her in the fitness world and became a huge fan and followed her journey for a long time. And then many years later, we both present at a fitness conference in Toronto every year. And so, as a result of us being presenters, not together, but in the presenter community, we got connected and she learned about my work and we've become really, really good friends. So yeah, Tosca's amazing. I still admire, I've admired her the whole time. And I just think that the way she lives life is something to be admired and aspired to.
yeah, she was way ahead of her time, I think. You know?
Yeah, for sure. So let's talk about you and your story. I know we have a couple of common connections as well, like such as Tracy Share, but I'm really interested in how you got into doing what you do and how you got into doing that.
So I'll tell you a
And
little bit about that. I started doing ultrasound at the beginning of time. I'm like a
okay,
thousand years old and
also
just
ahead of your time
um,
then.
rehabilitative work. It's holding up. No, but I really technically did start doing ultrasound when ultrasound was in its infancy. I had the ultimate blessing of being able to go to Johns Hopkins for my training at a time where Hopkins was Mecca. I literally say that I worked with the gods of ultrasound. When the ultrasound community was, there were 6, 7 people, some of the best out of Canada, actually. Some I had huge crushes on. Peter Cooperberg, if you're still out there, and Ted Lyons, both of them major people from Canada who were doing amazing early work. And I think over time, I had a real love for women. I just realized that women sort of got the short end of the stick. And when I started in obstetrical, not even to mention gynecological ultrasound, I don't even know if you're old enough to know this, but we did static ultrasound. So there was no real time ability to see organs move or hearts beat or babies move. We literally had to create the image. I then had an opportunity to go to South America to pioneer ultrasound. My chief couldn't go, and I was Spanish or Hispanic, and I had to look up Chile on the map, and I literally gave one of the first courses in ultrasound in Santiago, Chile in the 1980. 1980.
Wow.
I met my former husband there, and then we found ourselves shortly after getting married and moving to France. In France, they would not let me scan, and I was devastated.
Wow.
And I actually ended up doing a master's degree, but I did all my research back at Hopkins. So Hopkins was always a safe place for me. But then I found myself always teaching the next big thing, because I realized very early on as a young woman that doctors didn't seem as open to new technologies and things that would help women as I thought they would be. So the first things I were told with ultrasound was it's a tool looking for a use. It's useless. We have CT scanning. We weren't going to scan babies with CT. And that set me on this course of always looking at the next big thing. So one of the big things I taught was endovaginal ultrasound. Endovaginal ultrasound revolutionized being able to really see the pelvis for the first time. Because if we scan transabdominally, people didn't realize it was like going to the bottom of the ocean, especially in obese patients. So forget about finding perimenopausal, postmenopausal, pelvic pain, endometriosis, adenomyosis, those things were not even on the radar. Unless you had a big mass or huge fibroids, we weren't going to see very much. So the advent that started with fertility of endovaginal ultrasound, even in the beginning, the vaginal ultrasound was considered invasive. Come on. And still to this day, you can go and have an ultrasound somewhere in the States, and I don't know how it is in Canada, where the sonographer will hand the probe to the patients and say, you put it in.
That still happens here too.
So for me, I felt like we were doing such a disservice. It took me 15 years of teaching to integrate locally, and I gave some of the first courses in vaginal ultrasound, the vaginal probe as the standard of care. In fact, the mentor who I think before we planned this podcast that I worked with, Dr. Anna Parsons, who was a world famous reproductive endocrinologist at the University of South Florida here in Tampa, this was 25, almost 30 years ago, used the vaginal probe. She called it image-based gynecology. So her vaginal exam was, instead of doing this, I think I can get up to your ovaries, right? She used the vaginal probe. And I had an opportunity to work with her. I actually sort of, like I do a lot of things in life, I just sent her an email and said, I have to work. If I have to empty your baskets, I will work with you, because she invented what's something called the saline infusion. She invented this idea of being able to open the endometrial cavity, put fluid, which was conducive to sound, and now see polyps and things. It was mind-blowing. She was doing stuff that every other doctor I worked with wouldn't have even imagined. And one of those interests, shortly before she retired, was being able to probe for pelvic pain. And that was kind of the last of my work with her. So she opened up this world of realizing we weren't paying attention to women with chronic pelvic pain at all. And it's horrible. Much less like women who have prolapse, for instance. Still in this day, I do stand-up comedy. And I would joke, do you know what a pessary, for your viewers, I don't know that people know what a pessary actually looks and feels like. It's a donut hard rubber shape that's used to hold up your organs when there's nothing left to do, when they're literally hanging out of you. And I just kept thinking, this is so awful. This is the best we have in 2000, and this was before the pandemic. So my interest in the pelvic floor and being able to do a gynecological ultrasound and offer the patient so much more. Because I always used to say that women hold everything in their pelvis. Their pain, their sadness, their traumas. It's all held in the pelvis, and we never address that. And so then when I stumbled across your stuff, I was like, oh my God, I want to have a cup of coffee with her and pick her brain for like 3 hours, just so you could take something back. Because if you could say to a patient, look, there's actually some exercises that might save you from having to have surgery or peeing in your pants when you do jumping jacks or when you sneeze. And that doesn't seem important. Of course, in your world it is, but.
Yeah, there has been for a long time a slow evolution. And I'm noticing that there is greater, I'm going to say, uptake of the preaching that I've been doing for a long time with regards to the importance of pelvic floor health. So it's starting to become more talked about. More people know about pelvic floor physical therapy now, but it still has, I would say, a decent way to go. And you've come up with some of the similar barriers that I've encountered for longer. And some of those things still happen where there's not as much buy-in from the medical community with regards to pelvic floor physical therapy or imaging or other therapies that could potentially be helpful. And I think, again, it will continue to evolve and there will continue to be more collaboration. I just feel like I always say we need a village. we need a village for our healthcare. We need a village for our vaginas, and we deserve the collaboration amongst different healthcare professionals. We simply, in my opinion, cannot rely just on a doctor. We need them for pharmaceuticals. We need them for surgery. We need them for referrals for things like ultrasounds. We also could benefit from so many other providers, and it's about the education that comes from various opinions that allows us to then choose the best option for our bodies.
But I think the more we talk about it, I'm actually doing this again, and it's probably been 15 years since I did it. I live next door to the Catholic high school that my girls went to. And when my oldest daughter was in 9th grade, because I taught gynecology and ultrasound, there was always all kinds of things in my car, or charts, or,
Sounds like me too.
right? And just all kinds of, apparatus in my car. And I would find that some of the young girls would come to me and sort of talk openly about either some sexual experimentation or what their fears were. Something led to another, and I got invited, and I did an introduction to young women's health. Well, almost 15 years later, my kids don't go to school there, but I'm doing it again. And the same issues, I was contacted by a young woman, and I think, God, if we still have, in 2023, in an elite Catholic school, little girls that raise their hand and say the way they started their period, thinking they were dying and bleeding out, we're certainly got a long way to go to talk about pelvic health and how to reduce pain and have optimal sexuality, blah, 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 blah. Because if we don't talk to them, they don't get a refresher course when they're 20 or 30, No,
and along the way, they've had all these changes that have influenced their pelvic floor, not knowing what's considered normal, maybe feeling shame and embarrassment, not sure who to talk to. And then, many years go by, and then all of a sudden they're now perimenopause or postmenopause, and they're thinking, how is it that I've gone this long and now I'm just learning this? And I love that you're talking to the school girls, because if we're talking about bodies and menstruation and sexual health, sometimes that's not even being covered. But if we are teaching that in schools, why not talk about this really important group of muscles called the pelvic floor, and how it will be influenced by menstrual cycles, how it will be influenced by pregnancies and childbirth, how it will be influenced by the transition into menopause. I just feel like we have such a missed opportunity there. And I know the UK has actually stressed and talked about the importance of teaching it in schools. I don't know yet if that's been implemented, but why is that not a global practice that's happening, right? So I want to go back to your ultrasound first before we start to get too much into the weeds. But
I could get.
Yeah, I know. So could I. So many of the listeners would be familiar with what you were talking about before, the ultrasounds that many of us who have been pregnant may have had, where there's a probe and it goes all along the abdomen, and you can see images of the uterus and baby and what have you. So many of us are familiar with that. And then the pelvic ultrasound, as it's sometimes called, or vaginal ultrasound, is a longer sort of wand probe that is inserted vaginally that allows us to see other images. And I have a story to tell you in a minute, but I'd love for you to talk about what is endovaginal ultrasound. How does it work, and what is it looking for?
Oh, goodness. Okay, so here's the idea, is that the uterus and the ovaries sit closer anatomically to the vagina than they do by approaching them from the external portion of your abdomen. And one of the problems with conventional, what we call trans-abdominal ultrasound, scanning on the outside, that's like what a pregnant woman often gets, is that there are things that are barriers to sound before we often get to the uterus and ovaries. One of those being bowel gas. Sound is in its la la la, like it's the best way to conduct sound is to transmit sound through fluid. So if you try and transmit sound through bone, or on the opposite extreme, something like gas, it's like throwing a ball up against the wall. It just comes right back at you. So if we start from the outside and are trying to see a normal shaped uterus with no abnormalities and tiny ovaries, there's a lot of bowel gas that sits in between it. So unless we fill tortuously the female bladder, and anybody who's ever had a gynecological transabdominal scan,
I know that feeling. Yeah.
In their pants, they've peed on the table. It's just, there's no right or wrong. It's just, you're going to wait. It's going to be horrible. And so everybody associates this terrible exam, but that still doesn't ensure you that the bladder is going to illuminate enough up and over the uterus, depending on where it's at anatomically. And your ovaries, especially if, for instance, the left ovary sits up higher and out of the way. And if you have constipation, forget about it. The vaginal probe was initially designed for infertility, for us to be able to look at follicles up close and personal. In fact, some brilliant people have often referred to endovaginal ultrasound as sonomicroscopy. Sonomicroscopy. It's like putting a microscope in your vagina.
Mm-hmm.
And then you don't have all the obstacles that you often have by going on the outside of the abdomen. Because now not only gas is going to get in the way, but if there's any intra-abdominal fat, again, now you have to get to the bottom of the ocean to see these organs. The vagina doesn't have a lot of perivaginal fat or perivulvar. There's just not a lot of fat there. So no matter often what the size of the patient, we're going to get some pretty decent images because we're going to be up close and personal. A lot of people associate pain with the vaginal ultrasound. Again, there's all this, oh, you're going to go in the vagina? You know, what are you talking about? And a lot of people have had terrible experiences. Mm-hmm. Because if the sonographer has been taught in an environment where the vagina is like horrifying to them, right? They're often aggressive, and then there's pain associated with it. And then God forbid that on top of it, you've got vaginismus or chronic pelvic pain. You've done the patient such a disservice. But the nice thing is that vaginal ultrasound doesn't require a full bladder, so you're done on an empty bladder. You can use lubricant, so there's no reason we should have pain. And done well, you know, you can do it even in a young girl who uses tampons. So you just get this beautiful image of the uterus and ovaries that cannot be obtained through a transabdominal ultrasound. Mm-hmm, mm-hmm. We can use the two in combination because sometimes there is certain pathology like uterine fibroids that get so big that they sit beyond our range of being able to get up in the belly. But for the most part, especially looking at perimenopausal and postmenopausal ovaries, vaginal ultrasound there's just nothing that compares to it.
Interesting. Okay, a couple things before we go deeper into it. I just want to ask, with regards to ultrasound, can prolapse be seen in either the transabdominal and or the vaginal ultrasound?
You know, that was an interesting question that you're thinking. And I was reading through your book and looking at the exercises that you talk about, hyperpressives, right? Mm-hmm. This idea of being able to sort of suck your belly in, right? And obviously pull up that sling, right, of the pelvic floor muscles, and then pull things up. My question is, and that was part of the reason of talking to you, is that could there be something now that we could use in ultrasound, and perhaps it's already being done, where we actively, real-time, get patients to practice those moves to say, are you affecting the lower pelvis? And when you let go, do we see this descent?
Yeah, they are using ultrasound. I know Diane Lee has done some work with it, and a colleague of mine, Trista Zinn, who does Hypopressives Canada, she's been working with a few people on ultrasound. So yes, they are doing, and they've seen some really interesting things. To my knowledge, I don't know this 100%, but I believe it's transabdominal ultrasound. I don't know if they have done any vaginal ultrasound.
Be interesting. I don't know why we couldn't, you know. You just have to have more of an open-minded patient. But I don't know why we wouldn't be able to tell I think you'd almost have to have a baseline ultrasound. I mean, because the patients that I've seen with prolapse, I mean, most of their things are just...
Yeah, if we don't know how it presented before, is this different than what it was before? So, yeah.
And, you bring up an interesting point, and it's something that I've talked about for a long time. And again, I don't know when, I don't even know if I'll be alive if this ever gets implemented. But I often used to say is, I think done well, it would be awesome to have ultrasounds done at milestone periods in a reproductive cycle, especially perimenopausal and postmenopausal. Because now you realize, what am I taking architecturally into this part of my life? Mm-hmm. What does this landscape look like after all these years of whatever it is that's happened to it? Do my organs sit a little bit lower? Do I have fibroids that I'm taking in? Do I have para-ovarian cysts that are benign but are going to get overcalled like crazy because that was normal for me, but it's not normal to a radiologist reading an exam in Texas somewhere.
Mm-hmm. So yeah, it's interesting because I think a lot of testing thyroid, a full comprehensive thyroid panel, full comprehensive female hormone panel. I look at practices like this, and now what you said as well also is another one. I'm like, yeah, that makes total sense. Where if I think of I appreciate there's costs associated with those, but when I think about the costs associated with those to give baselines, to act as a prevention versus the costs of the subsequent surgeries or pharmaceuticals or missed work or like all of the other costs that happen as a result of what could have potentially been caught along the way and managed better. I don't know why our healthcare systems, I know that's a very big conversation, but why is prevention not considered? I'm hoping with
us to have conversations like this, that in hopes that a few women listen to us and say, mm-hmm. This is no longer crazy talk. For less than what you buy a designer purse. I mean, I charge $250. But I use 3-dimensional ultrasound. Your images make you the virtual patient. I can reprocess them after you leave. We can tell you hormonal status. I mean, it's just this terrific, and we can assess pain.
Okay, so I want to go on the hormone piece first, and then I want to come to the pain. We were going to focus on the pain, but the hormonal piece is super interesting as well too. So when you are doing an ultrasound, what do you see on the ultrasound that would indicate the hormonal status?
Well, I think it's looking at the ovaries and the follicular function. Ovaries have a terrible rap in the business of gynecology. If you came in and shadowed me, you would hear on a daily basis, well, I have cysts. I have cysts. I've been told I had a cyst. I had a cyst removed. My mother had cysts and I have cysts. And we've made cyst this horrifying thing, right? You have cysts, there must be something wrong with you. Instead of being told, how do your ovaries work? And one of the things that I like to do is, and this I learned from my mentor, and this was 30 years ago, she had a small little screen for the patient to watch. And she would say, here's your uterus. Your uterus is anteverted. It's this. It's shaped normally. It measures this. Here's both your ovaries, your late 30s. You have 7 follicles on this side. You have 8 on this side. You have a corpus luteum. It looks like you ovulated from the left, right? We can tell all of those things. And in women who are often beginning as early as mid-30s, starting to face either reproductive issues or autoimmune issues like PCOS and all these things, we can start to say, what are those follicles doing? This ovary looks like it's almost postmenopausal.
So you see that because you don't see as many follicles, is that right?
So what's interesting is it's even better than that with great technology. I mean, but it's so exciting. I know I'm like geeky, but I have like the latest equipment in ultrasound. That's always what I've done. So it's literally like doing a dissection through the ovaries, and what you see in the postmenopausal ovaries, we become eggless, right? I always say they go to Hawaii. They pack their bags and off they go, right? And characteristically, there's an ultrasound appearance, and the follicles are almost non-existent, and there becomes this almost like rim around the ovary that is just the classic postmenopausal. So it's an inactive ovary, right? So you can start to see, and see, I do a lot of infertility work. There's often one. In fact, I'll even go as far as to say there's a workhorse ovary. One ovary seems to do more of the work. She must be the female ovary, you know, than the other one. So there are things like that. We can tell where you ovulated, when you ovulated. So if you came in and you were on day 12, and I see a big fat, a corpus luteum is the secondary cyst that develops, I shouldn't even use the word cyst, but that develops post-ovulation, we can see signs of that. And they get funky looking too. Those are overcalled all the time. But I studied with this woman. All we did was research for 2 years on studying the corpus luteum. The corpus luteum gets overcalled as masses and potential cancer and blah, 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 depending on where you are, over and over and over again. So there's so much. And then there's the whole world of PCOS. And it's endemic. I don't know what it's like in Canada, but PCOS as a condition, I've never seen so many cases of PCOS.
Interesting. So yeah, and corpus luteum. So that's our progesterone source. And when we don't, if you weren't looking and didn't see, you know, you said you can tell where you've ovulated from. If you're not seeing that on either side and there's no corpus luteum, that's a sign of the perimenopause, where we're now missing that ovulation, and we're therefore not getting the progesterone to offset the estrogen, and then we get the estrogen dominance and, you know, all that kind of thing. So that is so interesting. And so that would be such helpful information to so many people. I remember going through perimenopause thinking I was crazy. I thought I was having heart attacks. I thought I had all these things before I knew the term perimenopause and all the reasons why everything was
And as a
changing.
sonographer, what I witnessed, because I was so passionate about women, and I've always been chatty Cathy, you know, I'm Cuban, so I guess that's just I talk to them, and I would realize when you are in the age that you start to go into perimenopause, it's like when shit gets crazy in your life. You know, your early 40s, many women nowadays have young babies because they started a little bit later. They might find themselves still heavily involved in their careers, right? So they have careers, they have young children, they have a spouse that may or may not be helpful, but we know women do 80% of most of the stuff, you know, that has to do with the home and the kids. They're the default parent. They might have elderly parents. So now it's this storm of just managing and putting out fires, right? And then all of a sudden, your ovaries start to say, oh, hell no, this month, no, you know, we're not doing it. You can't possibly have a baby. And when you start to like have times where you do and where you don't, you're going to see that reflected in your menstrual cycle, right? And then the symptoms that go along with that. But when I was young, when a 40-year-old would come in, it was just, I would see the, you know, whoever the attending was, they would just pat the women on the head, and here's the beginning script for Zoloft and antidepressants. And so you look at the chart, and nobody's talking to them as like, are you happy in your marriage? Are you okay? Is everything okay? How's work for you? How's the kid? Oh, you have a child with autism. Are you losing your mind? You're managing that and your job and your husband and your parents. And now perimenopause.
And things, and asking them about their menstrual cycle. Have you noticed some shifts? Do you notice any clots? Is it painful?
Are you on the birth control pill? Have you been on that for 20 years?
And incontinence symptoms and all that.
You know, there's just, we open up a can of worms, and it was a passion of mine because I personally went through it. When I went through a tumultuous divorce in my early 40s, it was crazy making. I found out my former husband was gay. This was not something a Cuban Catholic girl grew up learning that might happen. And I remember my gynecologist saying, well, let's get you some Zoloft. And I took Zoloft for like 2 or 3 days, and I was a big runner. And I remember feeling like I had an out-of-body experience. I was like, I'm not doing Zoloft. I will use exercise. I started boxing because I knew I had to find a voice and an answer for the insanity that I was dealing with. And then physiologically, your body's changing, right? And that can last for 10 years. 10 years, if not earlier, because the data shows that it might even start at 35. You know, we have so many patients that go into premature ovarian failure very early on. So, I think the psychological components that women face at that stage of their life are never harder. You know?
And all of this information would help ease some of the confusion and the anxiety and the worry and concern that goes along with all of that. So you talked about ovarian insufficiency. So primary ovarian insufficiency is something that could happen potentially earlier. So that's something that you could tell as well. And then you talked about PCOS. Can you talk a little bit about what are you looking for? What do you see in people with PCOS with your ultrasound?
So I am not a physician. I am just a sonographer. Well, not just a sonographer. I'm an old lady sonographer. So that really, I mean, it does. I paid my dues. But you know what I find about medicine? I went into medicine to make people feel better. I always thought fundamentally, was it not our job when they left us that he had just made their world just a little bit better? And when I see a woman who comes in with PCOS, there's almost a little bit of an appearance. Not always, right? But often you'll hear a woman that comes in that will say she's struggling with being overweight. You might find that as you're just sitting there and looking at her in the chair that she might have some excessive hair. Some of them might say, oh gosh, I have to get it waxed or lasered, or it's everywhere, it's crazy. And then when you put the vaginal probe in and look at the uterus, but particularly the ovaries, what you find is a bunch of what we call almost a string of pearls or a rosary bead kind of appearance. So where the ovary has eggs, and they're often all of different sizes, in a normal patient who's of reproductive age. In a patient who has PCOS, you'll see multiple, sometimes 20, 25, tiny little follicles, little cysts, but they never get any bigger than like 2 or 3 millimeters. So it's essentially this ovary that isn't doing its job. And what I think the data shows right now, which is fascinating to me, is that there's probably a lot of environmental influence, right? But there's an insulin resistance often in these patients. So something about them, I think, needs to re-look at an inflammatory issue, like either perhaps not eating gluten or watching, like wear a continuous glucose monitor. What are your sugars doing to the day? Are your sugars responding because you're not telling anybody you're drinking a bottle of wine a night? You know, I'm not saying that causes it, but I think the stress and all of the things that some of these women are dealing with are exacerbating and then sort of leaving them in this state that can be managed different, especially if we start to address their sugar issues. Like the glucose goddess, do you follow her?
Yes.
Oh my God, another woman who I would like kill to just get her brain, you know, because just like your work, we don't have to accept that.
Yes.
Normal.
And it's interesting. It'll continue to be interesting, I guess. What happened with COVID it sort of forced the hand of many practitioners to move online and for us to look at healthcare delivery differently. And it opened up a lot of people's eyes to the possibility that there are other providers, there are other philosophies, there's so many amazing health practitioners, health promoting practitioners in the world. And it's now what I have seen anyway, my own medical doctor, she chose to leave allopathic medicine because she said, I don't know root causes. I'm not trained to treat that. I'm throwing drugs at people. It's not how I want to practice medicine. So she left allopathic medicine and went to pursue, I don't know if she's doing functional medicine or what she's now going to do. I haven't followed up, and I heard that a few times where people were sort of a little bit disillusioned maybe about what they went into and was it really truly serving people. And again, that's kind of where I think now we absolutely need allopathic medicine. We need those practitioners for so many things. I don't believe they should be our only source of health promoting advice. I think we have such an opportunity again for that collaboration to happen. And I hope that is going to continue. I've seen it happening a bit more now, and I'm hoping that it will continue so that we have these multidisciplinary clinics that have all of these people that you don't have to see all of them, but they all potentially could help for the best interest of this patient to help them be well and live well and not be stuck on a medication they feel is the only option.
Or surgeries that often...
Or surgery, yes.
serve them as well, you know?
Yeah. So I want to talk about pain. This one was interesting to me. How can you diagnose pain with ultrasound? And so there's many different types of pelvic pain.
And so that's sort of an interesting question, maybe to throw back at you, and then I'll tell you where I think, because that was one of the things I wanted to pick your brain about. So as your expertise, do you conduct a vaginal exam? And then do you probe them for pain with your finger? Because that's what's done in pelvic floor therapy, isn't it?
Correct. So I am not a pelvic floor physical therapist, so I do not do internal evaluation and treatment. I work in collaboration with pelvic health physios who that is what they are doing. And then I have exercise and lifestyle and posture, breath, all those different types of strategies that can then help that person with certain, like not all pain diagnosis, but so things like, obviously a hypertonic pelvic floor. So really kind of overactive, non-relaxing muscles. That's something that I could assist with. Dyspareunia, like painful sex, again, depending on what the causes are, what the root causes are of that painful sex, I can potentially play a role in there as well. But more so pelvic floor physical therapists, they, they do an internal evaluation with gloved fingers to feel for tone, to look for organ position, to assess the capacity of the person to contract and fully relax their muscles. They may assess them with their fingers, yes, digitally. They may assess them in certain positions, so not just laying down on the table, but maybe standing upright, maybe doing movement like a squat, maybe on their hands and knees. So they can assess in all sorts of different positions, because the presentation of organs and the reaction time and force of muscles changes with different influences of gravity or movement or that type of thing, right? So with like my interest in when you were talking about pelvic pain is, again, there's so many presentations. It could be in the vulvovaginal tissue. It could be at the entrance to the vagina. It could be pain thinking about something happening and actually not involving any touch whatsoever. And so there's lots of nuances.
That's the interesting one, right? This idea of chronic pelvic pain. It's almost, that's one of the things that I felt like I could speak to, because what I would see is the patient is that, what did you call the first one? The hyper...
So dyspareunia, non-relaxing, like hypertonic.
So that's what I envision is a woman who's...
I don't understand.
Sorry.
Please
That's
use
okay.
I don't know who's talking to me, but I feel like they have an opinion. I feel like those patients, you can almost physically sometimes see them. They're doing this inside, right?
And sometimes they, like with certain, with some non-relaxing pelvic floor or potentially vaginal atrophy, potentially vaginismus, the probe may not even be able to be inserted.
And so what you end up finding, so I've learned this from doing young girls, because my always was a big thing was that you can almost have early onset of vaginismus because you're anticipating pain, right? That's why often young girls, when they have sex for the first time, it wasn't pleasurable, because I often say women, the vagina's a freaking muscle. Like it's a muscle like crazy. So if you want, it could keep a Mack truck out. And so you see that in ultrasound, because what happens is that one of the techniques that we help like be able to even do the exam is that patient who presents, they put their feet in the stirrups, right? And you know, I'm really gentle and kind, and I show them the probe and really lubricate the end. And the probe, if this was the probe, it's just the end of the probe that actually goes in the vaginal canal. But you can see their legs go like this, and every part of their body is doing that. And so you literally go in and you feel like you're hitting a cement wall. So one technique that I learned from my mentor was that they have to trust you, right? But you have to get them to let their legs just fall out. If they close them like this, you're up against that. And you can see that that mentality of a patient, especially if they come in and say they're having pain with sex, right, with intercourse, is because they're already anticipating the pain. So imagine their poor husbands, right? Not poor husbands, because poor them, right? But they're going to try and go in up against this. And no one's taught them that, probably through your technique and posture and breathing and letting their legs open, all of a sudden that introitus relaxes just a bit. And what it does, then once we're past the introitus, everything's a piece of cake. So the pain in some patients, that's an evaluation that we can do, and you can see that, and you can almost sort of say, hey, here's what you've got to practice doing if you're attempting sexual intercourse. And there's so much more to that. That's my world, right? The other thing is using the probe the same way the pelvic physio does, right? Is almost in a clock-like fashion to sort of test in, you know, sort of 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Where are they the most reactive to pain? And some patients are reactive to pain in the tubal areas. So we often wonder if they're not suffering from just a low-grade sapingitis, right?
Can you describe what sapingitis is?
So the tubes, you know, there's stuff that can be sucked up. If I did a study with this great guy out of Canada, Ted Lyons, and one of the things he showed with ultrasound was the uterine endometrial waves. So our uterus, when we're in the part of the cycle that if we're in reproductive age that we can get pregnant, the uterus sucks things up, right? It's brought from the vagina, technically sperm, to bring it up to our tubes. But the same way that happens, the way we can have low-grade sort of just germs or what have you. And sometimes you can just be suffering from a little bit of this sort of low-level inflammation of the tubes that can be treated often with antibiotics or with have a 2-week course, and the patients come back and they no longer have the pain, and that's where ultrasound can probe. Is it there? But you need, just like you can't go to just anybody. You have to be able to have somebody who understands the anatomy so well and has such a good picture that you can do this type of exam.
Right. So the
gonna pay for this, you know.
The vaginal ultrasound is not, like, from a pain perspective, it's not the imaging where you're looking for pain. It's the reaction of the use of the probe.
Because you can go right to where the tubes are and probe them there. You can see it. You could probe the ovaries. You can probe the uterus. But I think in my world, in terms of what I've seen women suffer for is this idea of holding all our pain and our contraction. And maybe you can talk a little bit about that. What type of person? Is that a type A personality? Where does that, is that from stress? Is that childhood womb?
That's all of the above.
All of it, right?
Yeah. Yeah. There's so many different factors, and there's no one type of person that is more like it can happen to anybody for all sorts of reasons. So at what point would you, so before we started recording, we talked about a mutual connection, Tracy Scher, who is the pelvic guru. She's a pelvic floor physical therapist in Orlando. So tell me how you know her, but then I also want to talk about, when do you feel like this could provide value over seeing a pelvic floor physical therapist? Should they be done in conjunction potentially?
Yes. I mean, I think just like you said in the middle of this conversation, wouldn't it be great if this was a tribe of providers? You could say, oh, I know, you're suffering from pelvic pain. What are you having? And then I've learned from you the type of language to say, oh, you have it with this, you have it with that. Here's a great book you can try. But in the meantime, let's see if we can get you in to see Tracy. And that's how I learned of her and realized that pelvic floor therapy wasn't even just for women. It was for men with chronic pelvic pain as well. And it was just this whole world of this idea of getting a massage, but of an area that no one ever talks about, being able to loosen those muscles. Mm-hmm. Or like you said, we have knots here. You have the pelvic equivalent of that. So much pain is held in our pelvis. There's a midwife taught me this. Well, she didn't teach it to me, but I used to hang out with her. It was called Mayan massage. Are you familiar?
My abdominal massage. Yep. The Arvigo technique. Yep.
Yep. So it was just about being able to kind of put our uterus back in balance, no? And you can see that with ultrasound. You can see how things like constipation and fibroids and things like that change the orientation, and we can sort of manually move it so that patients have maybe some relief. And then there's the whole world of constipation.
Yeah.
It's endemic. Yeah. How many women suffer with constipation? And we don't talk a lot about African American women who I think have an increased incidence, certainly in my patient population. I think from the time they're little, there's some language that's being told to them. I don't know what it is. I haven't done enough psychological research in that category. But I would say, as opposed to my Caucasian patients, African American patients, and they just accept constipation. It's just normal. And it shouldn't be. It's a noxious, horrible...
Yeah, I'll be doing a whole episode dedicated to constipation with some of my favorite gut health people. So I'll have several conversations on that. But so Tracy, I know she's very well known around the world for pudendal neuralgia, and this is it can be debilitating chronic pelvic pain. Can your imaging help provide any further help with diagnosing that at all? Have you worked with her on that?
I haven't. I would love to. I tried to kind of reach out to her after my physician retired, because it was mostly Anna that was referring the patients. And then Anna retired, and then the pandemic. But since I've been, like you said, on social media, I'm finding, there might be a voice for all of this. And there are some dynamic women that are changing the narrative like crazy. And that would be an interesting study. So Tracy, if you listen to this podcast, call me. I would love, I just think we could use ultrasound collaboratively to say, oh, Susan, look for this. But I feel like I need a little bit of a pelvic floor specialist to guide me, you know?
Right. Yeah, fair enough. So at what point, what you've mentioned kind of maybe landmark times where people could come in and have baseline testing, but also if they are experiencing pelvic pain or things they're not quite sure of, maybe they know they have PCOS, at what point should they, like, and I guess especially in Canada, you need to request that from your doctor. So they would request a vaginal ultrasound, correct?
So I don't know how patients could see you, right? But now I started a practice 24 years ago that said, I'm not taking insurance because insurance will never pay me for one, the caliber of the ultrasound machine. I have the latest technology. I started doing 3-dimensional ultrasound, which is this ability to look at the uterus in 3 planes and the ovaries. It's beautiful. It's amazing. It reduces the amount of time we have to scan. So if we've got a patient with pain, we can do an acquisition and they get off the table in less than 5 minutes, right? So we've just got these techniques that insurance I knew would never pay me for. And, you know, I just decided that if a patient wanted to see me electively, they needed to. Because the only patients that were going to see me electively were those that had gone above and beyond and realized they had listened to someone like you, they had seen someone like Tracy, and realized that what was being conducted in most OB practices with corporate medicine, and now post-pandemic, I'm sorry, is suboptimal. We're not training young sonographers to really do this type of work. Giving them 5 minutes to scan, you know? We're not using 3D, so we can't save the image so we can post-process it. And we're certainly not training the sonographer to say, what's your lifestyle like? Can I recognize PCOS if I scan ovaries? Can I recognize one ovary that looks postmenopausal and the other one that is the the ovary that is the workhorse? Can I recognize adenomyosis? I think you said you had a history. Was it you?
Yes.
Adenomyosis is a really tough diagnosis. You have to be trained to know how that looks. And that's a big changer. The same thing with fibroids, on and on and on and on and on. And
so if you have your own private practice then, excuse me, and do you have a physician in your practice?
And I'm going to say something super controversial. I was married to a radiologist, but I'm sorry. Radiology nowadays, they're in a room in Texas reading exam after exam after exam after exam. In fact, the guy from Canada, who I obviously am obsessed with, Ted Lyons, said years ago, the biggest problem that we were seeing in radiology is we needed to bring the radiologist back on the floor. They're not in the room with us. So right. An old lady like me who's been doing ultrasound for 40-something years, those guys wouldn't know how to scan if their life depended on it.
So sorry, who do you have in your clinic that helps you make the diagnosis?
It's me.
It's you.
When I had Anna, so it's just me, and then the radiologist, it gets read to have a formal report. But I know
does the patient
super controversial, doesn't it?
Well, it's
the state of healthcare.
It's the way that it has been done to now is, and it used to be, and I've noticed a little bit of a change, but at least in my experience, when I go for an ultrasound, the screen is not shared with me. All you can look at is the face of the person, and if it depends on what they're looking for, you're thinking, is that a good face? Is that a bad face? And then they're like, okay, I'm all done, and the results will be whatever. Your doctor will be in touch with you. So it's the time and the uncertainty, and we aren't allowed this information about our own bodies. And
it's craziness. I have a 60-foot flat screen TV That was my doing 25 years ago, because my doctor friend had a small one. I was like, why don't we put a big flat screen? So when I did my room, that's what I invested in. Because my thing was, if I did one thing, I didn't give a damn how controversial it was. I was going to give you the best ultrasound possible, and I was going to teach you about your anatomy, not Joe Blow's anatomy, but your anatomy. How does it work? How does this look? This is why you need to come back, or you look great. You don't need anything for a while. You know, it was, and I grew up in an academic center. So my whole youth was spent teaching and teaching at least 15 or 20 doctors around me. And then when I came to conventional obstetrics and gynecology, 35 years ago, this dictate came down that said you're not allowed to speak to the patients. And so you know what happened? Nobody speaks to the patient. Mm-hmm. What is that about? In a half an hour, you can learn about their lives. You can learn about what they eat. You can learn about whether they had sexual trauma. You can learn so much that says, take a little magnesium. Let's get you to exercise. Let's get you to drink more. You need more fiber. You could read Kim's book, and there's some exercises that maybe will save you with that incontinence that you've been suffering for.
And when the people can see the imaging of their own bodies, there's power in that. There's this knowledge that, again, that's kind of what I was referring to as well with what happened with COVID, was for so long, there's been gatekeepers, and we haven't been able to access our own body information, our own health information. And now there's companies that you can do blood tests online. You can, like, there's so much more, the CGM, as you talked about, continuous glucose monitors. We have access to now so much that puts us in the position of power. And again, I'm not saying we don't need allopathic medicine. We absolutely do.
No,
but let's,
I believe in it, but
yes. And let's include the patient, the person, in the discussion, in the process, and allow us access to our own health information. So I love what you're doing with sharing the screen and helping people understand, this is where this is where this, I see this happening, and giving them a place, that could potentially be their starting place, right? The point for them to start with, and then go to a doctor, then go to a physio, then go to wherever.
I give all the patients a copy of everything they get. It's really high tech, HIPAA compliant imaging that goes directly to their cell phone. So that if you had an expert in Canada, or say you read the exams, right? I could send it to you on your phone, and you could take a look and say, here, this is where it's at, right? But you would be surprised, and I'll tell the patients this all the time. I said, your doctor's not going to look at this. Your doctor's not going to look at this. I make it available to you. It's all available. Your doctor's not going to look at this. And it's a shame, because we've come so far with this technology. Mm-hmm. And it would save the system so much money to not have to put all these Band-Aids on top of stuff when we address the initial issue. And I think that's why we have to start back at young women and start all over again, when I teach to them, and I'll do this in 2 weeks. I start with the Netter's, Frank Netter, if anybody who's ever taught anatomy, I love Frank Netter, a Netter slide of a vulva. And when these kids walk into the room, and they're 9th graders to seniors, the first picture they see is a humongous vulva. And they all lose their minds. And then all of a sudden, we use humor. And my stories and my horror stories of growing up, like, inevitably we'll always get one of the kids that ask, oh, Mrs. Guidi, I popped my cherry. And I'm like, there's no fruit in the vagina. There's never been any fruit in the vagina. And you uncover these myths, because you realize, how many times are we showed a vulva? Do you even know what it looks like down there? Mm-hmm.
And the vulva's not the vagina.
And the vulva's not the vagina. Ladies and gentlemen, the vulva's not the vagina. There's just... I am so excited, because I see women doing great things. We're changing the landscape of this. So in the few years that I have left doing this, And it's a lonely job being way ahead of your time.
Yeah.
It's a lonely job. But I've had some patients that we've made all the difference in the world for, you know?
Yeah. Amazing.
And
Thank you for your thank you for your work and for sharing a little bit about how you can play such an amazing role in helping people better understand their bodies and what's going on inside. And I'm grateful for pioneers like you, and hopefully there'll be more collaboration amongst us pioneers in the future.
Yep. All right, my dear.
Thank you so much.
You're so welcome. It was an honor.